Okay.
Yeah, we had pieces before that actually.
And
Yeah.
let's get
So
ourselves.
it's getting more common. Makes sense.
Make sure we're in focus there. That's way out. So let's get ourselves on the screen first. Okay, everybody get your eyes in. Okay. So, is everyone in focus? And then we're going to have to look a little bit at schedule because we've lost a lot of Mondays to visiting professors, all of which are great lectures, but the residents, especially the first years, tend to get a little antsy if mock boards are coming in service exam and we haven't covered all the chapters yet. So we're going to have to look at how we're going to get things in.
And you're out of town a couple, like 3 Mondays.
That's
right?
the problem, is we're going to lose like 3 Mondays to that. So either we move forward and have fellows teach on those days, or we put other things those days and just move them and
We have a quiz next
together.
week.
Yeah. And
Correct.
the fellows can certainly do the quiz. That's not a problem. So
In-service is later this year
April for us.
instead of February. Okay.
yeah.
So that's good.
So that helps a little bit. It always used to be April, and then they moved it forward, and people were concerned about that, especially as it's changing to a basic exam from the in-service, and the in-service is going away, that, you know, it's not enough time for people to be ready for that evaluation. Okay, so Shane, you want to start us out?
Well, I'm not blinded, so I can't. I can, but I saw the answer.
Oh, you saw the answer. Well, but the answer that you saw may not be right.
It may not.
So what do you think?
So up there, when I first saw it, I thought it was sort of spitzoid on top, but they're not like really hanging down. There's just like some clefts there.
So first off, the top part, does that suggest that it's malignant or benign, and why?
Well, the melanocytes look like they may be at the dermal papillae rather than at the tips and sides of Reedy in some areas, potentially. So that would be bad, but the cells themselves.
So if they're at the
Okay.
top of arches,
Right.
that would be bad.
Okay.
Is it something large or something small?
Something small. It's well.
Is it it's well circumscribed? Is it well nested?
I mean, there are nests there.
Are the nests similar in size and shape and round to oval?
They are.
If it's small, well circumscribed, well nested, and the nests are round to oval and
Then
similar in
benign.
size and shape, it's
Okay.
probably benign. Now you do have some stuff going on down below.
Mm-hmm.
So what's going on down below here?
Well, you have smudged chromatin.
So first off, you have all of these things. And these are all just melanophages. They're not even
Okay.
melanocytes, right? And then the melanocytes that are there are few in number. Their nuclei are relatively small. They certainly are not vesicular, balloon-like. They're a little bit hyperchromatic, and there really isn't any discernible chromatin pattern there. So you put that together and you got what?
Well, the like bulbous shape. Yeah.
So it's got a bulbous shape,
Mm-hmm.
and
And the small like hyperchromatic cells would be like a variant of a blue, or like
And what kind of variant of a blue?
a deep penetrating.
Like a deep penetrating nevus. And not all deep penetrating nevi are deep or penetrating, but most are, which is how it got that name with the big bulbous thing. What's characteristic is the heavy surrounding melanophages and the small, somewhat hyperchromatic nuclei, inconspicuous nucleoli, smudged chromatin pattern. That's what's characteristic there.
Dr. Elson?
Yes.
The nest of the DEJ then, is this like a combined nevus or
Yeah.
is it all part of the blue?
It's a combined.
Okay.
Yep.
Just curious.
You can have compound DPN, but the cells at the junction would look the same, and here the cells at the junction were very different. So it's just a combined nevus.
Okay.
Yep, absolutely correct. And most blue nevi are combined if you look hard enough.
This one, yeah. Lots of nests. I think I see some pretty large nuclei kind of up near the dermal junction.
Okay. So can you tell if this one is well circumscribed?
Yeah, I don't think I can tell. It's edge to edge, so
Because it's a, what kind of biopsy?
punch.
A punch, and the lesion goes to both sides, right? So all bets are off in terms of circumscription, size. Does it end in a nest or not end in a nest? Nevi usually end abruptly in a nest. Melanomas usually trickle off with onesie-twosie cells, not a solid nest at the end, right? In this one you can't tell because it's the punch out of maybe the whole thing, maybe the middle of something.
Right. I feel like the nests are kind of discordant in shape and size. Some are like not all just like the tips and sides.
Some variation in size. They're certainly not all round to oval.
Right. I mean, I'm definitely worried that this would be a melanoma.
Yeah. So, more needs to be done. Probably the best thing for this one is not, I'm going to call our scope here. There we go. Not to get special stains on it, but to make sure we're looking at the whole lesion.
And more tissue.
Because the answer is probably in H&E and more tissue rather than in any special stain. In general, a broad shave for most lesions is better than a narrow, deep punch for most melanocytic lesions, just in general, which is why we tend to scoop a lot of melanocytic lesions. Okay.
So, I see a lot of melanocytes in dermis,
Okay.
and trying to figure out if there's lymphocytes in there, but I can't really tell.
So the lymphocytes are the little black things.
Right,
There are some.
but more so at the bottom. It's like some white spaces around.
Yeah, so the cells are not holding together well.
Yeah.
And you see that in a number of types of ordinary nevi. For instance, that any special site nevus will show that. And but you also see that in melanoma. So that's why special site nevi carry their name, because they share that particular feature with melanoma, that the nests are large and poorly cohesive. So when you see that, your question is sort of, is this special site nevus or is this melanoma? Anything else that might help?
Like looking for atypia.
So looking for atypia. And the rules for atypia are different for different cell lines. So for melanocytic cell line, it's a little bit different than for squamous atypia, but we'll look at some of those features later. There's certainly, when you look at the types of nuclei, this one has prominent nucleolus, that one's small and hyperchromatic. They vary one to the next. right? So you have a little bit of pleomorphism.
I don't see like a lot of mitoses.
So agree, not a whole lot of mitoses. The cells have a morphology where you have a nucleus that's off to one side and a lot of pink cytoplasm next to that. So in the path world, Jesse, how would you describe that kind of morphology?
Well, it's kind of like rhabdomyosarcoma, so we would say rhabdoid.
So rhabdomyoblasts have a peripheral nucleus that's round and then a big blob of pink next to it. So you refer to that as a rhabdoid morphology when it mimics that. And then the melanocytic world, do you think of rhabdoid as nice and warm and fuzzy or bad?
Rhabdoid's never good.
Rhabdoid is not good in the melanocytic world. Okay, so in this case, you're absolutely right. You don't see a lot of mitoses. You don't really see rip-roaring nuclear atypia, but you see a characteristic of nucleus plus cytoplasm that's characteristic for melanoma, which is a peripheral nucleus, big blob of pink next to it. That's a rhabdoid morphology. In the melanocytic world, that's usually bad. And then, you can talk yourself into, are the nests regular in shape or are they irregular, somewhat irregular, sort of confluent sheets? Now, this thing, is it large or relatively small?
Looks fairly large.
And maybe midland, sort of mid-range. And does it trickle off or does it end in a...
I mean, it kind of ends there.
Kind of ends in a big nest, right?
Yeah.
And the whole thing is pretty symmetrical. There is nothing more symmetrical than a metastasis, right? A metastasis is a ball, very symmetrical. This is metastatic melanoma. Rhabdoid morphology is your most common morphology in a met. So we talk a blue streak about symmetry. Mets are very, very symmetrical, right? So these are large sheets of poorly cohesive rhabdoid melanocytes. You don't really need to say much more. Okay. So this is a special stain,
Okay.
right? So it's a stain that's going to pick up melanocytes. And over here, you have atypia and disorder of the keratinocytes. You have a little background actinic keratosis.
Okay.
And you have melanocyte, melanocyte, melanocyte spread pretty far apart, right? So that's an AK. And this is all part of what the clinician shaved off.
Okay.
So, the clinician was aiming for a lesion. And this is a big part of the lesion, is just AK. Right? And then you've got, again, big part of a lesion. Pretty normal number of melanocytes, right? Not really jumping out at you.
Is this OX10, Dr. Alston?
Not SOX10 because it's cytoplasmic. See how the nucleus is a blue circle in the middle?
Mm-hmm.
So this is a cytoplasmic stain, more like a melanate. SOX10 would just be the dot of the nucleus with no cytoplasm. This is kind of the opposite. And then you get yet another one. And all the way over to the side here, you suddenly have runs of melanocytes.
Okay.
So how do you interpret this whole thing? There's that one little run of melanocytes, and yet the clinician was after something big. That's one small part of it.
So you mean within it there would be something like a junctional melanocyte?
Well, so that comes down to when you sample, what are you normally looking at? So you've got a big mottled, so this is a piece maybe the size of a quarter out of something that was 7 centimeters across. The clinician took a pretty broad shave, but what were they aiming for? Probably the blackest, darkest part. The blackest, darkest part is going to be the part with the greatest pigment incontinence, not necessarily the part that's most diagnostic for melanoma. So this ultimately was proved to be part of a huge lendigo maligna. There was some diagnostic struggle with this part. So there are studies that show that a 4 millimeter punch out of something that is lendigo maligna, there's an 80% chance it will miss the diagnosis. So you're going for the darkest area with a 4 millimeter punch. There's an 80-20 with only 20% yield of accurate diagnosis, 80% yield of wrong diagnosis. That's pretty bad, right? Which is why we don't do single little punches in the question of lendigo maligna. You can do broader shaves, or if you're looking at something that has 8 colors in it, take a little shave of each of the 8 colors and put them all in one bottle. That way you'll never miss the diagnosis. Okay. And in this case, this one is just in there as an example of how much of it can be actinic keratosis or benign solar lentigo. So what percent of lentigo maligna have within the confines of that lentigo maligna large areas that are pigmented AK or lentigo? It's half. Half of all lentigo maligna. That's why there's so many different colors, because it's not all one thing in there. There's going to be AK in there, there's going to be lentigo in there, and often the darkest area is not the most diagnostic area, which is why we sample all the different parts. So, Caleb, you have just done the biopsy and you did it brilliantly. You sampled every little color in that, you took shaves of every, and you put them in the bottle, and it took 12 little shaves. And you put them all in a bottle. How many biopsies do you bill?
1.
You are correct. It's 1 lesion. So no matter how many pieces of that lesion you take, it's 1 biopsy that you're billing.
If you separate them into 2 specimen jars, do you bill it like?
If you separate it into 12 specimen jars, then you bill it 12 times. However, what would be the clinical rationale and need for that?
Oh, I don't know. I was just curious because we bill it twice.
So there is a problem. And one of the reasons that pathology codes 88305 was decimated was prostate. Thank you for bringing it up, because there was clear data, pretty much incontrovertible data, that people who had well-established practices, they were more than 10 years into their practice, and they just internalized a lab. The number of specimens went up dramatically. Basically, they would start to divide every one of those cores out, and there were a lot more cores, and there were 12 biopsies billed, and yet no more malignancies were diagnosed. And it looked so bad that it resulted in a punitive action, and it was meant to curb abuses of physician groups, largely urology, also GI, that had internalized and built their own labs. Of course, every pathologist was, took part in the punishment of that. So, if you ask yourself the question, am I doing this for patient care or am I doing this to get a bigger bill? If the answer is only number 2, you're probably on shaky ground. All decisions should be driven by patient care, obviously. Okay, how about this one? So, Michelle, we got to pick up the pace a little bit now, but those were all important teaching points. Right?
So we have nests in the upper dermis, and it looks like there is some melanocytes around some vascular areas too, towards the bottom.
Okay. So everything around the bottom is small, round black cells. Those are all lymphs.
Oh,
the only melanocytes are the things up at the junction. So is the whole thing large or small?
It looks pretty small, like I could tell
Yeah,
the border.
say relatively small. You know, if you can count the number of reedy, it's probably small.
Mm.
If you run out of fingers and toes, it's big, right? So this one, you know, I can fit it just over a hand, right? So that's small. Does it end in a nest?
No.
I'd say pretty much yes. Maybe there are a couple of stray melanocytes, but I'd say pretty much yes. Nests vary a little bit in size. They vary a little bit in shape, but it's small, well-circumscribed, well-nested. Small, well-circumscribed, well-nested is usually going to be benign. So then what kind of benign thing could this be? It's all composed of small spindle cells. There's a lot of melanin. It was quite dark. It presented on the thigh of a 22-year-old woman as a really dark, new, well-circumscribed small lesion.
A pigmented spindle cell.
Pigmented spindle cell nevus of Reed. That's what Dr. Reed described, was these eruptive new, these were usually intelligent young women who came in and said, this thing is new and it's really dark. And the clinician never thinks it's malignant because it's small, it's well circumscribed, but you know, this intelligent person is saying this is brand new and it's really dark. And so you take it off, that's a pigmented spindle cell nevus of Reed.
So that's the clefting, right?
That's the clefting, just like in a Spitz. And this is probably a small cell. So if you're a lumper, this is an eruptive, new, small cell, spindled, purely spindled version of a Spitz that occurs on the legs of women. If you're a splitter, this is different from a Spitz because it's eruptive, darkly pigmented on the leg of an adult woman. And it's composed only of small spindle cells instead of large spindle and epithelioid cells. So, you know, it probably is a subset of Spitz, but it's a distinct subset. And it carries a name because of all those things we just mentioned.
So with acral skin.
Acral skin. So your differential in acral skin would be?
You can do like an acral nevus versus it could be type of melanoma.
Yeah, so acral melanoma or acral nevus, kind of off the bat. Do you see well-formed nests?
I mean, the melanocytes are at the tips, but they don't really have the round.
Yeah, melanocytes kind of aggregate towards the tips, but it's not really nested, right?
There's a lot of atypia in there. So.
And it's a little broad, so can be scary. But there's another thing you can do on acral sites. They're columns of pigment. Where does the column of pigment originate? In the ridge or the furrow?
The furrow.
And how about this one, ridge or furrow?
Furrow again.
How about this one, ridge or furrow?
Furrow.
How about this one, ridge or furrow?
It's all the same.
Furrow, furrow, furrow. They're all furrow. In dermoscopy, ridges are risky, furrows are
Favorable.
fine or favorable. Yeah. So ridges are risky, furrows are fine. So sometimes on an acral lesion, they can be very confusing, especially if they're cut obliquely, and it can be very hard to judge where it is in terms of the reedy. Look up at your corneum, because if it's all tight little columns and they're all furrow, it's fine, right? Ridges are risky, furrows are fine. So that's, you know, something that's very helpful for acral lesions. Let's go ahead. It's probably not appropriate for this box.
Kind of seems, first glance, similar to spindle lock. I don't see the clefting. There's a lot more inflammation here. It does seem well circumscribed though at the edges.
Well circumscribed. Now, is it all spindled, or do you have both spindle and epithelioid cells?
Both.
And compared to keratinocyte nuclei, are they smaller, like the pigmented spindle cell nevus, or are they larger?
They seem smaller.
I'd say if you look just at
Definitely
the nucleus,
larger.
yeah, at least some of them are larger. You do have mites, but they're only at the junction.
It's got hypergranulosis, little hyperkeratosis.
What's that pink blob? What's that?
Camino body, basement membrane.
Camino body, trap basement membrane zone. Important that must be basement membrane zone to be a Camino body. If it's a dead keratinocyte or a dead melanocyte that's red, that doesn't count. So if there's any question, get a trichrome. Should stain like collagen, right? Now I see buckshot scatter. I see pagetoid scatter all the way up to the granular. Is that bad?
Not if it's central, eh?
Not if it's central in the lesion. So it's got clefting, it's got Camino body. The nests, if you had to say how they're oriented, are they oriented side to side or vertical?
Vertical.
And the orientation of the spindle cells?
Also vertical.
Yeah, like bunches of bananas hanging down, right? So it looks like bunches of bananas hanging down. It's all vertical in orientation. The nests are tips and sides of reedy. They're Camino bodies. It's well circumscribed. The pagetoid scatter is restricted to the center of the lesion. Spitz. And Spitz nevi, they're also called S and E nevi for spindle and epithelioid because they should have, this may shock you, spindle and epithelioid cells, right? Is there such a thing as a purely spindled variant of a Spitz nevus?
Purely spindled?
Like on the legs of a 23-year-old woman. Yeah. It's called a Reed's nevus. Is there such a thing as a purely epithelioid variant of a Spitz nevus in an adult? It's usually called melanoma.
No.
No, it's usually melanoma. So, a purely spindled small cell on a leg of a young woman, that's a Reed's nevus. A purely epithelioid in an adult with no spindle cells is usually melanoma. That's why the S and E nevus, the name is good because it should, both elements should be there. If it's spitzy but purely epithelioid and you're in an adult, that's, often trouble. Okay, that's all you get, is that little bit right there.
I guess it looks like maybe some melanocytes down in these some perivascular and adnexal structures, maybe a congenital nevus.
Yeah, so maybe congenital. Are they round or do they have long, skinny, pigmented arms?
Like there's some dendritic.
Yeah, so it's dendritic. So you can have congenital pattern in blue nevi, that's very common. You can also have metastatic dendritic blue melanoma, which is essentially uveal melanoma of skin. Uveal melanoma is dendritic. Uveal melanoma, blue nevus-like melanomas in skin genomically are essentially uveal melanoma that just happens in skin, right? And it's dendritic, and it's similar to the melanomas that horses get, so sometimes it's called equine type melanoma, blue nevus like melanoma, uveal melanoma of skin. It's all the same thing. Pigmented epithelioid melanocytoma is a rubric that contains some of those, and some epithelioid blue nevi. So, this, you don't get much of a look at it. You probably want bigger cuts, because this could be metastatic blue melanoma, or it could be just blue nevus. You don't really get enough look at it or its stroma to help you in this particular case. So let's look at something different. So, Ying, what structure do you think we're looking at here?
It looks like a lymph node.
It looks like a lymph node, exactly. And if there were nevus in a lymph node, where would you expect it to be?
Metastatic melanoma.
So if there's nevus in a lymph node, it's going to be in the capsule. And we know that from years of breast nodes coming out, that a significant percentage of them have nevi. And they tend to be in the capsule or in the septum. The septum runs in like this, like fingers into it, and they're protrusions of the capsule into the lymph node. So in capsule or septum, that's nevus. Melanoma tends to be right in this area. Right subcapsular is where, so for those on monitor, subcapsular is where melanoma occurs. So if you're looking at a lymph node, and we're not going to look in detail in this one, but if you're looking for nevus, you'd expect it to be in capsule or septum. Melanoma subcapsular deposit. Usually a crescent-like deposit subcapsular. Okay, David, what do you see?
So these little dendritic pigmented melanocytes kind of scattered through the dermis, kind of upper third, they're kind of horizontally oriented maybe. I'm thinking like a nevus of Oda or Ito, something like that.
So how large is a nevus of Oda or Ito? Clinically on a patient?
Usually pretty big.
Pretty big.
This is pretty
This
small.
goes from there to there. So is it likely to be a nevus of Oda or Ito?
Probably not.
Maybe on a flea, but so it's just so small, and those are big, broad. So you expect that to go side to side, right?
Mm-hmm.
Okay. So this is just too small to be nevus of Oda or Ito.
Pigment incontinence, perhaps.
So maybe pigment incontinence, or
a blue,
or metastatic blue melanoma, or primary blue melanoma. So one of the things you can do without spending a lot of money is normal collagen is brightly diffractive. Blue nevi usually make new collagen, and new collagen is not brightly diffractive. So the first thing you do is you go down to low power, and you take your hand and you slide it in, and you look, is the whole thing bright, or does it go sort of black in a wedge?
It does have a blackened wedge.
It sort of goes black in a wedge, right, instead of bright. If it's clearly black in a wedge, that's usually a nevus. If it's bright throughout, that's usually melanoma, because it's trapping pre-existing collagen rather than making its own new stroma. So that's one of the simple things you can do just on H&E without any special stain. And then, of course, there are much more involved things that you can do. Most melanomas, well, first off, most nevi are b0f mutated nevi. Most melanomas have mutations on top of b0f, and those mutations are common things like telomere mutations, TERT, promoter, and 9p21, which is CDKN2A, which is the mutation in dysplastic nevus. If you just get 9p21 and you have nothing else, and you have that germline, you're going to have dysplastic nevi. You're going to be one of those families with lots of atypical nevi. You also have a higher risk of melanoma. Why? Because you already have one of the 3 most common mutations in melanoma, and you have them in every cell of your body because you have a germline, right? Now all you need is b0f which is pretty common. Almost every nevus on your body was a spontaneous b0f mutation, right? So that's pretty common. And then TERT promoter mutations are pretty common. So you happen to get those two hitting where you already had 9p21, now you've grown a melanoma, right? If you get things like BAP mutation on top of BRAF, you get a benign Wiesner nevus. You get a BAP mutation on top of GNA11 or GNAC, you get a melanoma. Same mutation, different background. Behavior is going to be different. So what's BRAF? Ordinary nevus, right? So you get BAP on top of it, you get a funny kind of combined nevus called a Wiesner nevus. What's GNAC and GNA11? That's blue nevi. You get BAP on top of a blue nevus, that's melanoma, right? The blue nevus, like melanomas, what's the most common secondary mutation? BAP mutation. And a lot of these you can look with immunohistochemical stains. So you're going to see a lot more of this, and that alphabet soup starts to become clinically relevant because that's how you're going to sort out everything is going to be an OMA. Melanoma, and now from a very practical sense. If I were trying to test your knowledge to practice competently as a dermatologist, there are certain things that would be straightforward. You know, can you recognize a pigmented spindle cell nevus? Can you tell that from a melanoma? Can you tell an acral nevus from an acromelanoma? A lot of the same things we've been looking at. The other is, can you interpret a report that you get from a pathologist and know what the important bits of all that gobbledygook that's in the report and what it means? And that would be a relevant skill set as well. So, do you read X-rays? So reading an X-ray is not your scope of practice. Do you interpret reports of X-rays? That is your scope of practice, right? Do you read fungal plates in your office? No. Do you get reports of fungal plates from the lab? Okay, so you know what's scope of practice, what's not scope of practice, what's testable, what's not testable, and that's all publicly disclosed and has been out in a letter to all program directors. Okay.
Looks relatively well circumscribed to me.
Relatively well circumscribed. Does it end in a nest?
Yes, sir.
Are the nests tips and sides of reedy?
Yes, for the most part.
Now, are the reedy themselves symmetrical?
No.
Or do they bridge and look like Swiss cheese?
Look a little bit like Swiss cheese.
Why do they look like Swiss cheese?
I don't think there's nests with any.
Because it's cut obliquely.
Oh, okay.
Right. So you tilt your epidermis and you cut it obliquely. You're going to make things look much more interesting than they would otherwise look. Right. So you interpret melanocytic nesting patterns in the context of the reedy pattern. Is the reedy pattern, cut properly, or is it cut obliquely? If it's cut obliquely, then you're going to, yeah, exactly. You're going to take that into account when you're looking at your nesting patterns.
The same thing, like on acral skin, like parallel versus perpendicular. Do you bisect your own?
Always. So anytime I take an acral nevus off, I bisect it myself before I send it to the lab, so I can be sure that it's bisected perpendicular to the dermatoglyphs, never parallel to the dermatoglyphs.
Because if you do it parallel, it looks...
If it looks parallel, because nests run in the furrow. Your dermatoglyphs are your reedy pattern, right? So if you bisect it right through the middle of a furrow, all the way across, you can't even tell that's a furrow, right? Because you have no ridge to compare it to. All you see is an endless confluent nest, right? And so, we did that study years ago where we took benign acral nevus, bisected it wrong, bisected it right, made 2 different slides and on 2 different dates sent them to university pathologists. We suckered everyone into calling it unequivocally malignant versus unequivocally benign, same lesion bisected differently. So always, bisect perpendicular to the germanicus.
If you're going to bisect it, also write a note on the requisition.
This is already, and actually I recommend not just on the requisition. Write it on the top of the container and stick that label across the top so you cannot open it without reading that.
Because we get lots of things, 2 pieces in the container, and if you don't tell us, we're just like, oh, there's just 2 pieces.
Then they
Shape,
bisect
so
each of those 2 pieces, yeah.
So if you would say, I previously bisected, please submit intact or something like that, we will do that.
And the other thing you should do is keep green Mohs ink in your practice, because green Mohs ink is the most viscous and it stays on the tissue when you put it in formalin. And you use it for all sorts of different things. You use it, one, if you want them to embed, like you just cut that, and you want them to embed it the fresh cut sides down, right? You just put a dot of green Mohs ink on the sides and you write on there, already bisected, embed ink side down. Now they know what to do, right? If you've got something and there's a dark black dot in it and you want to see that black dot, put green Mohs ink on it. Say, please bisect immediately adjacent to the black dot. Not through it, because then they'll rough cut it away when they're trimming the block, but immediately adjacent to it so that it shows up when they cut into the block. If you are cutting out a melanoma and this person is speckled with lots of little nevi, and those are separate discrete nevi, and you're going to end up cutting through some of them when you take that melanoma out. Now your pathologist is going to see junctional nests at the edge of a melanoma excision, right? You want to tell them this is just a nevus. Clinically, this was just a nevus. In vivo, you put green Mohs ink on each of those little nevi that you're going to cut through, and then you do your excision, and you write on the report, patient covered with incidental nevi, each of those dotted with green Mohs ink. Now I see in your margin, I've got melanocytic nests here, here, there, and each one has green ink above it. And, we published a paper that communication, you get rid of all your false positive margins for the melanomas. Because now your pathologist knows. You just communicated and said those were all just nevi in the periphery. And I had to cut through them because there's no, unless I cut like this, there's no way to not to cut through nevi on this guy. So, okay. So, Audrey, what do you think about this?
So the overall shape has this bulging, pushing border at the bottom.
Bulbous, downward pushing border that usually goes with
like a deep penetrating nevus of a variant of a blue nevus.
So some kind of blue nevus. The other thing that has that outline is childhood melanoma. Most childhood metastasizing melanoma has this outline. So do most blue nevi. And so next thing you do is you look at the cytology. If the cytology is that of a Spitz, a benign Spitz should never have this outline. ALK mutated Spitz with TERT promoter that metastasize because now they're melanoma, they have this outline. Whereas, and blue nevi have this outline. Ordinary Spitz nevi disperse into non-nested units at the base. So you have this kind of bulbous outline and your cytology looks like a Spitz, you got trouble. Your cytology looks like a blue nevus, that's what you expect. Now how about if I do fancy things like HMB45? Will this mature with HMB45? Do you have a gradient if it's a blue?
I don't believe so.
No, blues don't mature. Blues don't mature, blues don't disperse. They're not supposed to. So every stain you have to interpret in context of what the lesion is. So this one we're going to look higher. And they're all fusiform and oval with a vesicular nucleus and usually a single solitary central round nucleolus. That goes with what kind of lesion?
Benign.
Yeah, and specifically cellular blue. So common blue, the nucleus is dendritic. Small spindle nucleus, dendritic cell. Cellular blue, oval, vesicular, meaning looks like a soap bubble, with a central blue dot, central nucleolus. DPN, depenetrating, small, hyperchromatic, round to oval, inconspicuous chromatin pattern, inconspicuous nucleoli. Sort of the opposite of these cells. In a common blue nevus, you have lots of stroma. In a cellular blue nevus, this may shock you, it tends to be cellular, right? And so cellular blue nevi. Epithelioid blue, we're going to get to that in a second. So next thing you do is you take your hand and you put it in. Does it black out beyond just the cellular islands? Is there adjacent stroma that also blacks out? And the answer should be yes. So if you look at areas, like we're going to put our pointer right in here where it's not cells, it's just stroma, right? And we're going to turn down the light so you can still see where we're pointing to. And then you're going to put your hand in. If that whole area blacks out, which it does pretty well, that goes with it being benign. If that area stays bright, it's probably a melanoma. A epithelioid blue has no stroma. It's the only variant of a blue nevus that has no stroma. Looks kind of like a cellular blue, but it has no stroma. And it's totally benign. There are melanomas that look pretty much the same. That's where that term PEN, pigmented epithelioid melanocytoma, comes from, which is, this is either an epithelioid blue, and you have Carney syndrome, or this is a metastasizing melanoma. Right? And then there are other tests you can do to sort those out. And they share some of the initial mutations, and then there are additional mutations like TERT and 9p21 that are layered on in the ones that behave like melanoma. So why do they look so similar? Because they have a lot of the same mutations. Why do they behave differently? Because there are some mutations that are different. Okay? So where do common blue nevi occur? Scalp and dorsum of hands and feet. Where does cellular blue nevi occur? On your rump, right? That's where cellular blue nevi occur. Cellular blue nevi, dime a dozen, you're going to see edematous areas. That's ischemia because you have something the size between the size of a pea and a walnut that's on your butt and you sit on it all day and it becomes ischemic, right? So ischemic change in a cellular blue is a dime a dozen, really common, and it means nothing. And commonly gets overcalled as melanoma. Okay.
So, first of all, it's like a congenital pattern. It's maturing as it gets.
So it certainly matures, it disperses. It's patchy, interstitial, and perivascular, and periadnexal. So that's, common for a congenital pattern nevus. And then it has a different population of cells in it. So when you hit a melanocytic lesion and suddenly there's an abrupt change and there's a clone that's different, there are two possibilities. You know that took additional genetic hits, right? They either made it malignant or it's still benign, right? So either it's a combined nevus or it's melanoma arising within a nevus. So how do you tell? Well, you look at all of the histologic features, and then sometimes nowadays we look at mutations as well. So when you look at these, how would you describe these cells?
So I see some nuclear pleomorphism.
So there's a little bit of nuclear pleomorphism. Do they look like cellular blue? Are they vesicular? or are they solidly hyperchromatic?
Solidly hyperchromatic.
Do they have conspicuous nucleoli, or are they inconspicuous nucleoli?
Inconspicuous.
Do they have a prominent chromatin pattern, or is it an inconspicuous smudge chromatin pattern?
Smudge chromatin.
So they are relatively small, with the exception of a few, like that one that's a little bit bigger. Most of them are relatively small, hyperchromatic nuclei, inconspicuous nucleoli, smudge chromatin pattern, and then surrounded by big melanophages. Does that look like some lesion we saw recently?
Yes, that would be cellular.
Yeah, cellular blue has vesicular nucleus and prominent nucleolus. This is like the DPN, the deep penetrating nevus.
That's right.
So this is neither
nevus.
deep nor penetrating. It's a combined nevus, and it goes under lots of different names. One would be just DPN change in a nevus. Right, you got little clones of deep penetrating nevus within a benign nevus. At Tulane University, where Richard Reed, at one time Herbert Lund, who was in the Carolinas, and Richard Reed, who was at Tulane, got almost all the referral cases of funny melanocytic lesions in the South, right? Because they were the guys, right? There weren't that many guys in the South. And so Dick Reed at Tulane, in his practice, this was the most common combined nevus referred into him with a question of melanoma, right? So he named it the common combined nevus, right? So common combined nevus of Reed is different from pigmented spindle cell nevus of Reed. The only thing they have in common is they were both described at Tulane, right? So common combined nevus of Reed is nests of deep penetrating nevus within an ordinary banal nevus. Sometimes it helps to understand the names, how they originated. Okay, so this thing was obviously bisected, and this piece is not that much, and this piece has a little more. And what do you see here?
So there's the interface is sort of jumbled, and that's, I don't know if it's underneath there is like solar damage or
it's definitely solar elastosis. So this is an older person with sun damaged skin. I don't see a lot of flat red fibrosis. Most melanomas have a zone of flat red fibrosis that pushes the elastosis downward. This one really doesn't have that. But do you see any nests?
I don't.
Or is it just endless confluence at the junction?
Just endless confluence at the junction.
And do they all stay at the junction, or do some of them go upward?
There's a few upward there.
And it extends down the adnexal structures. But when you look at it, is it big or is it relatively small?
The biopsy is relatively big, but the actual involved portion is small.
Okay, so when you do a biopsy, well, first off, where do you see this process in the biopsy? Is it in the center of the biopsy or to one side?
It's to one side.
When you do a biopsy, do you usually aim to put the pathology at one edge of your specimen?
Usually not.
So to your eye, this whole thing was the lesion, and yet you see something that's very asymmetrically disposed within that biopsy specimen. Does that usually point to something good or something bad? It's usually bad.
Right.
I mean, it means what your eye saw as the lesion is not equating to what we're seeing histologically in terms of the distribution of melanocytes and things. So it may be that this area regressed or that it's a collision. I mean, it could be an incidental nevus arising if this is like adjacent to a basal cell and what they were sampling was the basal cell. But here, we don't see anything really in the center that they would have been sampling. So you look at the history. What are they going for? If they're looking for a melanocytic lesion, well, now I'm going to look a little closer. There is a little something there at the junction. There's a little something there. Are those the tips and sides of Reedy, or are they up in the arch?
In the arch.
What's your arch enemy?
Melanoma.
Melanoma is your arch enemy. So arches are melanoma territory, right? Does this thing end abruptly? Is it sharply circumscribed, or is there something here that's confluent, and then there's a big skip, and then it's still not ended? It still keeps on going, right? So those are all things suggestive that this is melanoma. And we're going to do one more important concept here. So, Caleb, what do you see?
Proliferation in the dermis mainly. Looks like there's kind of lymphocytes dispersed in with melanocytes here.
So what are the gray cells?
Gray cells. Some histiocytes maybe?
Yeah, probably all melanocytes, okay. The gray cells. And what are the black cells?
Lymphocytes.
Lymphocytes. And the lymphocytes, what is their relationship to the gray cells?
They're all been mixed in together.
They are all mingling together. Does that suggest something friendly or something adversarial?
Just friendship.
It suggests friendship. Whereas adversarial would be all the lymphocytes lining up at the periphery. Here they're invited in, they're all mingling, it's friendly. So this is the pattern of halo nevus, whereas melanoma, the lymphocytes are lined up at the periphery. Okay, just the last thing we should cover in the last 3 minutes. You're going to read a lot about new treatments for melanoma because we have all kinds of new things. A lot of them will work in some lesions and not other lesions, and what's predictive of that is what the mutations are, and you can recognize the mutations by the histology. So increasingly the histology will dictate what treatment you will use. A lot of the new treatments that work relate either to growth inhibition or immune checkpoint inhibition, and they work differently. So the old model of evading the immune system was that the tumor was somehow circling the wagons, right, and keeping the immune system out. The new model is the wagons are rolling along. The Indians, who are the good guys, the immune cells, they're coming in from the sides. But first off, the wagon's moving pretty quick. Indians can't take good shots. And the Indians aren't even that mad, right? It's not taking a whole lot of shots. So what two things can you do? One thing is you can slow down the wagon, right? Slowing down the wagon is never going to kill the melanoma. It doesn't get rid of the wagon. It just slows it down, right? So that the Indians can take better shots. What things do we currently have? That's b0f, things like vemurafenib, MEK. Those are all things that slow tumor growth. Only until other mutations occur that allow it to evade that. And then the wagon speeds up again. But for a while, all it does is slow down the wagon for a while so the Indians can take better shots. The other thing you can do is you can rile up the Indians, right, so that they really start taking out the wagon. That's things like CTLA-4, ipilimumab, and the new kids on the block that work much better, which is PD-1, things like Pembro, that really have changed the outlook for our melanoma patients. And what they do is they rile up the immune cells so that they take shots and kill the melanoma. The things like b0f and MEK all they do is slow down the wagon temporarily. They just weigh down that wagon for a bit. So it's like putting a couple of, big sacks on the back of the wagon. It's going to slow it down for a while until the sack falls off. Right? That's all you're accomplishing with things like BRAF inhibition. Whereas PD-1 inhibition, you're riling up those immune cells, making them take shots, and those shots are what ultimately can kill the melanoma. So that sort of puts it into two buckets of things that are simply growth slowing and things that are immune checkpoint inhibition that are really give you the potential to kill that melanoma, and why they're sometimes used in combination.
Jelson.
Yeah.
I noticed the book was mild, moderate, severe dysplastic movement. I know that we tend to read them out a little bit differently here. So you go to an institution that reads them out that way. I guess you follow the dermatologist's recommendation, but if they read out like severe, you would probably read
so
the
last data nationally are that the majority across the country read atypical nevi as mild, moderate, severe. They do grade them. The minority do a bimodal, which is it's okay, leave it alone, or it's bad, take it out. Which is kind of what a lot of clinicians in a perfect world, you'd kind of like sort of leave it alone. Is this a leave it alone lesion, or is this a take it out lesion? Just tell me which one it is. Some people like Dr. Mays forced themselves years ago into as much as they could bimodal. This one's okay or this one's take it out, which is why we do Clark's with atypia, melanoma, or many places do nevus, atypical nevus, cut it out, melanoma. Tells you what to do. But across the country, most places still do mild, moderate, severe. If you're in a place that does mild, moderate, severe, and the fact is it's hard to get away from some moderates because they exist, right? So if you're in a place that does mild, moderate, severe, there is excellent data that benign, low-grade atypical nevi, nothing bad happens if you leave them alone. It's just a nevus. You don't have to do anything else. So how do we report those? Benign melanocytic nevus with architectural features of a Clark's nevus, and we do not report margin, because if we reported margin, it kind of implies what am I supposed to do? We just said this is a benign melanocytic nevus. That's all you need to know about this one. Right? If it's a high grade, then we're going to tell you to cut it out. Right? So what do you do with those few that really are moderates? Well, there are a couple of good studies now that suggest that at least what some labs are calling moderate, nothing bad happens to those. But there are also data that one lab's moderate would have been, so most of those things that are called moderate, in Dr. Mays' bimodal, he would have called those nothing. Right? He would have called those low grade, Clark's. So he would have put all of those moderates into the low grade. There are also data that there's an occasional moderate that's another man's melanoma. That was called moderate by one group, but other good pathologists are calling it melanoma. And we did that with a little study that we did where we sent some around. There was one lesion that every last person at Yale, and there were 8 dermatopathologists that participated, were said it was a moderate atypical nevus, and Dr. Mays said it was melanoma. Neither group are stupid, right? These are some of the best dermatopathologists in the world currently, and one group is saying moderate and one group is saying melanoma, and there are data that, why did everyone in the Yale group say the same thing? Because they show things to each other all the time, and as a group they converge. You'll see groups converge, but those two groups that are geographically separate may be converging in different directions, right? So we published it, Yale and South Carolina and New York published that study jointly, just saying, be a little careful of the moderates, because one man's moderate may be another man's melanoma. So the solution is don't overcall moderates. The biggest study that said nothing bad happened with moderates came out of Mayo. What does Mayo currently do now? What is their department policy? Is moderates, if they go to an edge, they take them out. And it's because of that, they're pretty comfortable with their pathologist, and what their pathologist is reading a moderate is going to be okay. But there's still that little bit of uncertainty. And if you're not sure, especially who's reading your moderate, it might be best to have moderates out. If you're getting a ton of moderates, you probably need a new pathologist, right? Because most things either should be, it's fine, leave it alone, or this one is bad, take it out. There shouldn't be a whole lot of moderates. There may be an occasional, but there shouldn't be a whole lot of moderates.
And then severe, is it more a narrow margin, or is it like 5 millimeters?
So severe, treat like melanoma.
Okay.
Because there are good data that one man's severe is another man's melanoma. Okay, I gotta get to class. I am double booked all morning.